Good morning and welcome to the Stemi India this year meeting. And my topic today is Stemi and non-Stemi the definition adequate for optimum management of patients? So this is a paper which we published in the circulation on an On My Mind article of why we should now time to reclassify infarctions. And it's not important to define them as STEMI and non-STEMI based on an ECG because it was convenient. And why am I talking about this was this paper which we published of occlusions, inclusions, and exclusions, time to reclassify myocardial infarction. So the classification of myocardial infarction has been on the presence of ST elevation or ST changes on the ECG. The FTT trial revealed the largest benefit of immediate reperfusion in patients with STEMI with a tendency towards net harm in patients with ST depression or normal ST segment on their ECG. Remember, this trial is more than 20 years old. There was no troponin at that time, and a lot of unstable, the so-called unstable anginas were included in the study, which could have been non-cardiac chest pain and could have got harm when you thrombolize the patient. So though ST segment elevation has remained as the gold standard, it excludes an entire population who do not have ST segment elevation, but could have occluded vessels, which is called as OMI. So this is a paper which was published in the European Society Congress and subsequently published in the European Heart Journal by Deepak Bhatt and colleagues, which showed that a meta-analysis of more than 40,000 patients with Nstemi showed a prevalence of totally occluded culprit arteries in 25% of the patients. So it is not that non-Stemi is non-occluded. And this also study displayed that patients with non-Stemi and total occlusion had a significantly higher major cardiac event and mortality as compared to those without total occlusion. So the issue is non-STEMI is not so benign. You should not sit on it, and you should possibly act, at least in certain subgroups, very quickly, and especially those who have a suspicion of total occlusion. So we have a dichotomy of STEMI versus non-STEMI, and we know clearly STEMI equivalents on ECG criteria have been described to denote total occlusions, like the classic Wellens, the new onset LBBB with the Scarboza criteria, the hyperacute T wave or the De-Winter pattern, and the typical posterior wall infarction, which is only ST depression and no ST elevation. Many other patients with non-STEMI could have missed occluded myocardial infarction and be not offered emergent revascularization. These patients on follow-up show larger infarct size and higher event rates as compared to those without OMI. Conversely, an ST elevation from another cause, which we call as a ST mimic, such as the myocarditis, may unfortunately be offered fibrinolytic therapy, and which may be harmful. And this has typically happened in the COVID crisis. So what I'm presenting you is a single-center retrospective study of non-STEMI over a period of 1 year, which was carried out at Madras Medical Mission. The clinical features, the EKGs, the echoes, and the angiographic patterns and outcomes comparing non-STEMI with total occlusion versus without total occlusion was performed in hospital and at 1 year. So what was the data? So those non-STEMI patients, so we had two groups, one with non-total occlusions and one with total occlusion, a total 283 patients. And you can see a substantial group of patients, almost 36% of patients, had total occlusion. The difference was the age was lower when your vessels were occluded with non-STEMI. The time delay, that is admission to angiogram expectedly, was higher when your vessels were occluded. The mitral regurgitation was similar in both groups. The LV function of the patients in hospital with total occlusion and non-STEMI was lower than with non-total occlusion, both in hospital and at 1 year. So clearly showing that non-STEMI with total occlusions land up with low left ventricular function, which will obviously affect event rates in the long run. The vessels involved, there was no big difference between single vessel and double vessel, but you can see that the left main was very close to having non-significance. So these left mains are unlikely to be total occluded, expectedly, because those patients who get total occlusion will possibly have an ST elevation. No therapy difference or an angiographic difference between the two groups. But what was important was the LAD was less likely to have total occlusion with Nstemi, while circumflex was expectedly going to be higher incidence of total occlusions. What about the use of drugs or therapies? Heparin was most often used as a drug when you had total occlusion with non-STEMI, with an intervention expectedly, because we don't like bivalirudin when there is clot, and bivalirudin was the other way around when there was non-total occlusion. What about the events? Because this was a small study, the event rates were no difference in terms of stay, death, reinfarction, both in hospital and at 1 year. So the conclusion of the study was that patients with non-STEMI with total occlusion tend to have more circumflex lesions, less LAD and left main lesions, and they tend to have more thrombus within the lesion. They tend to be treated with heparin if they are occluded, rather than bivalirudin, and their ejection fraction are like to be lower at in-hospital and 1 year follow-up. The outcomes in this study was no different because it's a small number of patients. So the gaps in evidence today are what is the timing of occlusion in OMIs. Though they present as non-STEMIs and they're occluded, is there a timing to this? Is there an evolutionary ECG pattern, unlike in STEMI, where we clearly know what happens? The STs go up, the T waves go up, then the STs go up, then they reverse. Do we have an evolutionary ECG pattern? Can we rapidly and accurately identify OMIs outside a traditional ECG, and to test whether primary PCR fibrinolytic therapy and anticoagulants are necessary in this group of patients, which unfortunately has no studies. So this was the simple diagram which we put up in circulation. So you have a patient with non-STEMI and you come in with a very high risk non-STEMI. Obviously they go like an MR, or they have hemodynamic instability. Obviously we quickly take them up into the cath lab like a STEMI. You also have patients with occlusion which have bad outcomes, and this can be picked up on ECGs with various new criteria. They would also behave like STEMI, so they should go for urgent revascularization. And then there is another group of patients where there is a possibility of occlusion. Which are those patients? Ongoing chest pain despite treatment, say 1 hour of treatment of an non-STEMI, rapid rise in cardiomyopaths from 0 to 1 hour, and artificial intelligence-based ECG pattern, not a resting simple ECG pattern. If you have those criteria, maybe we should do a CT very quickly. And if there's occlusion on the CT, push them for urgent revascularization. If the coronary obstruction is more than 50, but not totally occluded, maybe they can have an earlier angiography and revascularization. And if there's no obstruction, they go for medical management. Those patients who have a high-risk STEMI with low risk of occlusion could have the traditional angiogram maybe within 24 hours and revascularization if necessary, and the low-risk non-STEMI without a troponin or anything could be medically managed. And this was the flow diagram that we suggested in circulation. So the future direction is we are trying to enroll about 1,000 patients with non-STEMI over 12 centers. We've got all the paperwork ready, and hopefully in the next month, subject to all these COVID issues, we should have a large registry of 1,000 patients to look at. So what's my conclusion? The classification of acute MI into STEMI and non-STEMI based on EKG is imperfect. The traditional ST elevation criteria exclude a sizable fraction of patients with occlusive myocardial infarction who may benefit from an urgent revascularization. Novel diagnostic tools like AI in EKG and computed tomographic angiography may help to identify these patients who could then derive benefit from an emergent revascularization. Thank you very much for your patient hearing.